Hello and how are you? My name is Winnie Bagawa. Welcome to our session on antenatal care for women who are living with FGM. If you're new here, this is a channel that focuses on lectures, lessons, and expert interview pertaining to healthcare. In this series, we are conducting awareness and sensitization against FGM, which is one of the harmful practices in our community. This series is supported by the Girl Generation in collaboration with ACAF and University of Nairobi, a consortium or a movement that is committed into ending the practice of FGM in our society. Keep up with me, and if you've not been following, you can refer to other videos pertaining the same within our playlist that we have written there, that is on gender and sexuality. So previously we had introduced FGM and what it means. We've looked at the drivers or the reasons why it's being practiced up to now. We've explored on statistics and prevalences, and then we looked at the complications, that is in terms of short-term complications and the long-term complications. And previously to this, we've talked about the obstetric complications, that is what can complicate in case a woman is pregnant and have been victims of female genital mutilations. So in this case, we're able to see complications such as or risks such as need for episiotomy, need for performing cesarean sections, but also could see risk for complications like prolonged labor or obstructed labor. Now, in this part, we're going to explore more of how do we take care of a woman who have gone through FGM and they're pregnant. So we want to look at the antenatal care that we can give for a woman who is actually an FGM case. So first of all, we're being advised that we need to do assessment of women of FGM, and this should be done as early as possible, preferably during the antenatal period. Hence, this can allow us appropriate and timely management, including the ability to refer them for skilled assistant or technical assistant to better skilled facilities. Now, in the previous classes, we did classification of FGM, and we said that FGM is classified into type 1, type 2, type 3, and type 4. Now, within the category of type 1, 2, and type 4 of FGM, we are told, or rather we are informed, that there is no major associated complications, and in the cases of pregnancy, labor, and even the delivery process, we expect that the woman may not be affected that much, or the woman may not develop risky complications. However, for the type 3 of FGM, which is one of the severe type of FGM, it's associated with high risk, or rather the highest risk of complications during delivery. And this is where we end up with cases like third degree form of tears or perineal lacerations, and the woman may be forced to be taken through cesarean sections, or the woman has to go through cesarean sections, obstructed labor cases, and so on. So with regards to the assessment of mothers or assessment of pregnant women during their pregnancy antenatally, we need to check the type of FGM that the woman has undergone. So this is going to help us prepare in advance or prevent further complications depending on the type. So keeping on, which antenatal care should we focus on? So the antenatal period may be the only time the woman is actually coming into contact with the healthcare system. Unfortunately, in communities where practice FGM, mostly you find this either in remote cases of our communities, or in larger cases, a small number of women may be found in the urban sectors. Now, when providing care to women living with FGM, at whatever contact you've been able to meet them, it is a bit important, or it's quite important, to be sensitive and respectful towards their cultural beliefs, values, and attitude. To remind us, when we looked at the drivers of FGM, it's seen that a lot of it is culturally driven or it's culturally instigated, and most of our women in this case practice this because that's what they believe their community dictates or their community expect them. So you have to be sensitive, understanding that this was not from a point of ignorance, but this could also be a point of culture influence. And they may not feel that they're doing anything wrong. In any case, most of the time they feel like they've done the right thing. The unfortunate bit is they have not really looked into the complications and the risk that it exposes the woman later in their pregnancy period. So what do we do in our initial evaluation? So we have the initial prenatal evaluation, and it's at this period that we're coming into taking history and performing the physical examination of the pregnant woman. So while doing this, it's very key, and we've been advised to prioritize that you determine the FGM status of the woman. And what do we mean by this? So in determining the FGM status of the woman, this is establishing the type of FGM that the woman went through. We want to look at the possible complications that the woman may be associated with. So if it's on a advanced stage of the pregnancy, let's say in second stage or third stage, you may encourage performing the ultrasounds or the scans to just see the general outlook of the development and gestation of the baby. And then in other cases is you want to see the type of FGM that the lady went through. If it was type 1, type 2, type 3, or is it type 4, and what are the likelihood of complication in this. So most of the time in the management, we mostly categorize our women in this case mostly under the high risk pregnancies, which will need us to do constant follow-up and ensuring that there's increased contact while they're coming for follow-up. So upon history taking, it's encouraged that, do not start by asking the client questions on FGM, because sometimes it's good to just do the routine history, the normal history, where you know about their biodata or their origins and biographics, get to know their demographics, and then take time after that. That's when, introduce the aspect of FGM, because the FGM is advised that you should bring it in when you're now exploring about surgical or reproductive history. Remember, under the history taking process, we have the step-by-step model, and we have the biodata, the chief complaints, history of presenting case or illness. You explore the past medical and surgical history. You go all the way to social and family history. And then for women, you can explore on obstetric history or reproductive history. Now, because this is a pregnant woman, we are told to explore in detail when we reach at the category of past medical and surgical history, and also when you're exploring their reproductive or their obstetric history. If you still have challenges on how to do a proper history taking, we've done a video on history taking and physical exam. I'll advise you go watch it. I'll also attach it in this video for you to refer to it, but you will see the different steps. Now, at the medical surgical history is when you're supposed to explore the FGM. So this you are advised you can be asked in the following way. For example, I know many women from your community have experienced some form of genital cutting. Do you know this? Do you know whether this was done to you? So this is an easy way of introducing the FGM concept to our women at this particular moment without judgment, without any form of prejudice, and it opens up a conversation to discuss about it. So if the woman openly answers you that the above question is yes, then you can go ahead and ask about the type, for example, that they underwent, the time when it was done, do they remember how the whole process occurred, and you want to understand that history with them. So when the answer has been explored and the lady openly explains to you that they were able to go through the FGM, inquire whether she experienced any complications. Explore, did she have any short-term complications? Did the lady go through long-term complications that she had to be intervened on? Then were there any complications during previous deliveries if she's not a primary patient, if she has been pregnant before, were any complications experienced then do previous history of any procedures or interventions to care for the FGM. For example, was there any form of deinfibulation with the previous pregnancies, or was she reinfibulated again after that? And explore any further concerns that she may have. This is still under history taking. We've not yet gone to physical exam, and we want to just understand as much details and explanations around her experience with FGM. And then after the history, we're now going to physical examination. So with the physical examination, this is to help us confirm the presence of the FGM and confirm the type of FGM that the women went through. So check for any conditions that may complicate the pregnancy, delivery, or interfere with any future vaginal examination. So you may do a nice vaginal checkup and or perineal examination, and you want to see how is the area like, how are the anatomies, were they affected, was there interference, how is the severity of the status, so that you can see if there's any interventions you can bring in place. So in the presence where you discover this woman has a type 2 FGM, then check the elasticity of the surrounding issues or tissues with your index and middle finger or a cotton swab and the bag. So in this case, we are told if the urethral meatus is visible or if the index and middle finger can pass into the vaginal opening without difficulty, it is unlikely that there will be mechanical barriers to deliver due to FGM. So it's good that you do the checkup, or it's good that you do the checkups. So the digital checkup is going to help us see the patency of the meatus to also confirm that the urethral or meatus is also visible and accessible. So this means we'll not have any difficulty during the second stage or during the time when we'll be conducting the deliveries. So in the physical examination, you've seen that we have done the digital checkup and we've been able to explore the urethral meatus and the vaginal meatus. And you can confirm that they're patent and they are good to go, meaning during the delivery period or during the second stage, there will not be risks or any risk of obstruction then. However, we're told when you have done the physical examination adequately, we need to now carefully record the findings to avoid repeated examination. For example, you can do a simple drawing to indicate the status of the examination. This is to assist with future examinations when someone wants to come and check again, so that you don't have unnecessary repeat examination, but rather we can focus more on the interventions and helping the woman prepare for the development of the pregnancy. So discuss the information learned from the examination with the woman and her husband or partner if they're present or if it's appropriate. However, if the woman has a tight vaginal opening due to type 3 or what we call due to the infibulation procedure, discuss the option that the lady may have to go de-infibulation. So with the physical exam, the need is to confirm that the woman has meatal adequacy or the meatus is patent enough or adequate enough to allow good progress with the pregnancy all the way to delivery process. But however, if you find that the opening is very tight, then you can advise the lady to prepare for de-infibulation as a way of helping open up the vaginal space or open up the vaginal opening to prepare for the deliveries. So at the end of the clinical examination, it is good to discuss the finding with the client and jointly agree on follow-up or a birth plan. So ask the client whether she has any questions and address her concerns appropriately. So with this, clearly record her findings from the clinical evaluation, be able to openly discuss this so that at any future encounters where possibly you as the team that saw her is not present, then she can explain it to the other team without hesitancy or without lack of understanding. So with this case, we are told you need to be as open as possible when you're handling clients with female genital mutilation or clients who've gone through female genital mutilation. As you can see, the process antenatally. Remember, this is the period when they're still pregnant and the pregnancy is not yet at the last miles or at the time when you're preparing for delivery. So do the history, go for the physical examination, check on the clinical exams or other evaluation that you need to do, and then address any findings or any questions that the lady has and jointly agree on the need for follow-up and also a good birth plan. So if the mother has further questions, always address them with her openly. If she's come with a partner, you can also discuss this together. But always remember to record your findings. This is to assist with continuation of care or continuum of care with other teams or to ensure continuity of care for the woman till delivery stage. Now, while we are managing all this in terms of FGM, we always have to think also of the complications that may arise during the pregnancy. For example, due to the experience of FGM, the mother may experience reproductive tract infection. Unfortunately, some of them are very recurrent and she may be on constant treatment to just clear that. There'll also be case of urinary tract infections, There could be obstruction of the vaginal opening. In some cases, she may have had epidermal inclusion cyst and keloids, cases of vulvar abscess, rectovaginal fistulas, or VVS and incontinence. So keep in mind that apart from discovering that either the opening is still closed or it's not adequate, assess also for other complications that may not be FGM related, but they may occur during pregnancy, and manage them appropriately. I really feel it's also good to do this with teamwork, that is, work hand in hand with the pregnant mother and advise or give management and follow up based on the needs and the discussions together, because this gives good support system. It brings in also teamwork, it brings in good cooperation from the client, and it leads to good outcomes or positive outcomes at the end of the management. Yes. And that brings us to the end of our session, that is on the antenatal management of a pregnant woman. And as you can see, we have emphasized on the case of proper history taking, physical examination, and the clinical evaluation, and working hand in hand with the mother and the partner to rule out any complication that may arise, but also to identify the type of FGM, to be able to also get to see the patency and adequacy of the vaginal opening and the urethral opening, but also look for any further interventions that can be done. So till now, guys, I really enjoy being with you, and remember to like our videos, give a comment. Let me hear what you think about it. Share this with your community or members of your class or members of your group that may enjoy and learn. And don't forget to subscribe. Click on the bell so that you can notify you when we post our next videos. Until next time, bye bye.